I am now pleased to introduce our first speaker, Kurt Giesa, the National Practice Leader of Oliver Wyman Actuarial Consulting's healthcare practice. He's one of the authors of a recent paper on options available to stabilize the individual insurance market, and we're so pleased that he's with us today. Kurt?
Catherine, thank you for the introduction, and I'm let people on the phone know I'm grateful for the opportunity to share some thoughts with you regarding stabilizing the non-group market. Catherine asked that I briefly describe the individual or non-group market before I get started. Chris Hallmeyer, who will be following me, will do this more thoroughly. But what we're talking about here is essentially the only option for individuals who don't have access to Medicare, Medicaid, or coverage through an employer. It doesn't represent a large segment of the under 65 population with coverage, probably less than about 10%. But it's really the only source of coverage for those who need it. So in that sense, it's an important market. I've got really 4 slides to share with you that I hope you'll find insightful. I have a slide that I hope helps explain the premium rate increases we're seeing in 2018 and the impact that a number of decisions had on those rates. In another slide, I estimate the cost of guarantee issue in the non-group ACA market and argue for an external funding source to cover that cost. And then I have a couple slides discussing the subsidy structure in the non-group market and the potential for change. So I'll start with my take on what happened with premium rates in 2018 and how we got here. This isn't meant to illustrate the extremes, but only to provide an example of how an issuer could have arrived at a relatively high or relatively low rate increase in 2018. Actuaries started thinking about 2018 premiums before 2017 data was actually available, but they had seen the results for 2016, and market-wide, premiums were about 9% short in 2016, and that followed an even larger shortfall in 2015. So the starting point for our 2018 premiums here, the rate increase, is really the 2016 premiums plus 9% to cover the 2016 shortfall. That's what I put in the first row of the table, the underpricing in 2016. Medical trends still operating in this market, and we're seeing increased use of high-cost services, more high-cost claimants. And I'd include here an anticipation that the risk pool may deteriorate. And so I made trend really 8% per year here for 16% total. We had the price for the end of the transitional reinsurance program that ended in 2016. That was worth about 5% of premium. That's just something that was sort of structural in the system that had to be covered. And now it seems like ages ago, but in February, the administration announced improved enforcement of SEPs, changes to the rules around the grace period, and an expanded de minimis range for AVs. We estimate that was about a 3% premium reduction. So if you take all those things together and add them up, you get about 27%. Now, premiums actually increased by 22% from 2016 to 2017. That's towards the bottom of the table, the effect of the actual rate increase, 2016 to 17. So we actually, of the 27%, we actually recouped about 22% with the 2017 rate increases. So if we'd stopped there, we may have only needed a 5% premium increase or going into 18, or if an insurer wasn't going to price for better enforcement of SEPs, maybe 8%, or if they were going to be conservative, maybe 10 or 12%. But of course, we didn't stop there. Instead, we've got a lot of uncertainty regarding the enforcement of the mandate from the executive order early this in the current administration, and then the IRS saying they wouldn't enforce the mandate earlier this year. We also have lack of CSR funding and what I've termed general regulatory risk. You add all this up, and you need to increase rates. This is what I show near the bottom of the table. You need to increase rates by somewhere between 33 and 65% to get from 2016 to 18. And again, we got 22% of that with our 2017 rate increase, so that leaves something like 11 to 43%, most of which could have been avoided. This is, of course, the recent past. That's what we're talking about here. But this market's been buffeted from so many directions for such a long time. we had transitional policies under the prior administration that allowed the healthiest lives to stay out of the market. They could keep the policies they had in force. And now we have the executive order on short-term medical, which we have to deal with that, and that may also allow the healthiest lives to stay outside the single risk pool. What this market needs more than anything right now, in my opinion, if it's going to function well, is some regulatory stability. Here's the next slide, and in this slide I develop the cost of guarantee issue in the non-group market as being worth about $15 billion. This analysis isn't perfect. I don't really think it's possible to do this analysis perfectly, but what we've done here is we've done our best using data from the federal MLR reports to develop an estimate of the cost of guarantee issue in the 3-to-1 age rating in the non-group market. Our starting point, the first bar on the left, is the average premium in the non-group market in 2013, so before the ACA, trended forward to 2015 using the change in group premiums between 2013 and 2015. This yields the premium that I show there of $284 PMPM. Our starting point is 2013, as I said, so this includes the cost of the ACA provisions that went into place before January 1, 2013. For example, coverage of dependents to age 26. The next bar, network discounts that I show here at $31 PMPM, is something that's difficult to estimate with precision. You know, the effect of network discounts or narrow networks on pricing, but so this is based largely on our experience and our judgment. But we used an estimate that network effects are worth about 7%, actually lowered costs by about 7%. The next bar, geography, measures the change in the distribution of business by state between 2013 and 2015. The subsidy structure makes coverage in high-cost states relatively more affordable, and we wanted to estimate that effect, but you can see here it isn't large. It's only $6 PMPM. The increase in taxes and fees of $15 or $180 per year, $115 PMPM or $180 per year, that comes from a comparison of 2013 expenses trended to 2015 compared to actual 2015 expenses. So that's a measure of how much expenses increased trying to, due to regulation and things like administering the risk adjustment system in 2015. And that's $15 PMPM. A large change here is what we estimate for the cost of benefit changes. This is the increase in AVs. So, prior to the ACA, AVs were about a 0.6. Post-AV or post-ACA, the AVs in 2015 we think are about a 0.7. We also have EHBs included here, pediatric dental vision, mental health and substance abuse parity, and we estimate all these effects to be worth about $51 PMPM. The next factor, rateable demographics. This reflects the fact the market got a lot older between 2013 and 2015. Issuers could rate for that, of course. They could charge higher premiums for the older population, but only up to 3-to-1. I'll discuss this in a minute, but the 3-to-1 for age and the subsidy structure have made coverage much more attractive for an older demographic than was the case pre-ACA, and so the market's really skewed older, and that gives us a $50 PMPM for rateable demographics. Now, if you skip a bar and go to the far right, the $436 PMPM, this is the average premium in the market in 2015. And the thing that gets us here, the bar next to it, or the little bar next to it, what I've termed morbidity and unrateable demographics, you can think of this as the cost. This is the balancing item, the thing that we really can't explain. And you can think of this as the cost of the societal good, and you could put good in quote marks if you'd like, but this is the cost that policymakers put into this market when they required guarantee issue and modified community rating. Anybody who wants coverage has access to it, and they can't be written up if they're in poor health. This costs about $62 PMPM, or about $744 per year. This cost is actually being paid in two ways. If somebody's eligible for premium subsidies, their $744 for the year is being picked up by the taxpayer. The premium subsidies cover it. But for those who don't have a premium subsidy, they're being asked to pay this cost out of pocket. So you could really say to yourself, well, what we're doing here by requiring guarantee issue is we're asking anybody who's healthy, who wants access to the market, to pay an extra $744 to gain access, more than their real cost. A couple interesting things about this value. First, recall that the penalty is the greater of the penalty for not having coverage is the greater of 2.5% of income, or $695. I don't know if the policymakers who drafted the legislation and came up with the penalty level had some idea that the cost of guarantee issue might be about $750 PMPM, or this $744. But it's interesting to me that the penalty that you have to pay if you stay out of the market is pretty close to the cost that you have to cover if you're healthy and you want to come into the market. The second thing that I think is probably more important here is if you take the $744 per year, extend it by the size of the non-group market in 2015, and then trend it to 2019 or 2020, you get about $15 billion PMPM. And so that's my estimate of the cost of guarantee issue in this market. It's about $15 billion PMPM. We've done a lot of work with our microsimulation model. One of the things we've looked at is the effect of funding a $15 billion reinsurance pool, external funding, say federal funding for a reinsurance pool of $15 billion. And we estimate that it could lower premiums by more than 20%, bring in a number of healthier individuals. And a large majority, this is one of the sort of oddities about the way the subsidy structure works, but a large majority of this $15 billion would come back to the federal government in the form of lower APTCs, lower premium subsidies. Lower premiums mean lower premium subsidies from the federal government, so the feds would recoup a large share of that. And actually, I just note that this level of premium reduction and the kind of the return of the funding back to the feds is consistent with what Alaska was able to accomplish with their reinsurance pool. So I've really got one more concept to share with you, and this has to do with the way the subsidy structure works. And obviously on this slide I've got two charts. The chart on the left, I'll start there. We've taken a premium of $433 PMPM. That's the value that ASPE reported as the average lowest cost silver premium in 2017 in the healthcare.gov states. And we developed premium rates by age that an actuary would like to charge in the market, essentially using an age slope of about 4.8 to 1. That's sort of the underlying spread in costs by age in this market. I like to think of these premiums, these actuarial premiums, as really the true cost of coverage, and those are the dark blue bars in the chart on the left. That's the actuarial premium. We also developed premiums using the ACA's 3-to-1 for age. We use that slope. Those are the light bars in the chart on the left. And in this chart, the chart on the left, you can see we show premiums for age 24, 44, and 64. And we also show that the 24-year-old is paying about 37% more than their actual cost of coverage. And the 64-year-old is paying about 7% less. The 44-year-old is paying slightly less than their true cost of coverage. But this is the effect of 3-to-1 on age. It makes coverage more expensive relative to the sort of the underlying true cost for young people and less expensive for old people. Those premiums are premiums before premium subsidies. On the chart on the right side, we show the out-of-pocket cost of coverage after premium subsidies by age and by FPL. Now, FPL is along the x-axis at the bottom. Recall that at a given FPL, the amount an individual has to pay towards the cost of their coverage is the lesser of two things, the actual premium they're looking at or a fixed percentage of their income that varies only by income and not by age. So in this chart, you can see what this means. It means that at 150% FPL and at 200% FPL, the 24-year-old and the 64-year-old pay the same amount out of pocket towards the cost of coverage. At 150% FPL, it's at $720. At 200% FPL, it's the $2,400. Those are what they'd have to pay each year to gain access to coverage. But at 350% FPL and above, that's about $41,000. The 24-year-old and the 44-year-old aren't receiving premium subsidies any longer. You can see the premium they're paying For example, for the 24-year-old, the dark blue line under the 350% FPL, they're paying a $2,613 premium. That's the premium under the ACA in the chart on the left for a 24-year-old. Same is true with the 44-year-old. They don't qualify for subsidies anymore because the percentage of their income they're asked to pay is greater than the premium that they're looking at. So what this means, you can see that the 64-year-old still receiving a large subsidy at 350% FPL. They're paying roughly $4,000 for coverage, but the premium is $7,800. So I've got one more slide to share with you, and this is kind of another way to look at the situation. I think that a lot of the work we've done is assumes that people have some sort of an intrinsic idea of the amount of the health care they need, and what I've been calling kind of the actuarial premium or the actual cost. And I think this serves as a pretty good proxy of the relative value of coverage by age. So in other words, with a 4.8 to 1 age slope, that means the 64-year-old will place about 5 times the value on having coverage as a 21-year-old. And in this chart, we show how the actual cost of coverage after premium subsidies compares to the actuarial premium or the true underlying cost. Again, I'm showing age on the x-axis here, and the dark blue bars are for 150% FPL. The 0.38 for age 24 at 150% FPL at the far left, you can see that 0.38 there. That means that FPL, 150% FPL, the 24-year-old's paying 38% of the actual cost of the premium. If you go to the other side of the chart and look at the dark blue bar, somebody age 64, they're paying just 9% of the actuarial premium or the true cost of coverage. At 250% FPL, that's about $29,000. The 24-year-olds actually paying 126% of the premium. So this is somebody who's age 29. They're really getting no help in covering the actual cost of coverage. They're paying more than their actual cost of coverage. They're paying 26% more than their actual cost of coverage. This is due to 3 to 1 age and the fact they don't get premium subsidies at that level. While the 64-year-old, if you go to the other side and look at the light blue chart, they're only paying 28% of the actual cost of their coverage. So you can see that really at every age and every FPL, older individuals do better, and in some cases much, much better than younger individuals. I think these values are the reasons the pool is skewing older, and I understand that changing the subsidy structure is difficult politically, but until we make coverage better for younger individuals, more affordable in particular, the pool, I think, is going to continue to skew old, and the market won't be able to adequately serve that segment of the population. So I guess the question is, what does the non-group market need? And this is just my perspective, and it's really a pretty limited look. There are lots of ideas out there, but what I've put forward here, I think the market needs stability and consistency from policymakers. It needs funding to help pay for the cost of guarantee issue, some sort of external funding. Doesn't have to be a reinsurance program, but somehow we need to get premium into the market to lower the cost of coverage in this market to cover that societal good that is guarantee issue. And finally, we need a subsidy structure to encourage broad-based participation. So those were the slides I wanted to share with you, and thanks very much for your attention here.